Alright guys, welcome back. So now, in the last video we did question numbers 1 through 25. I went ahead and spent a pretty good amount of time to go into detail, talk about how you would get this question right, what it is that you should have thought about, what your approach should have been. These are all things I definitely want to talk about in every question I do. And one thing that was very particular that I was noticing as I was going through NBME 21 is that all the questions I did so far had images to it, right? And that was really annoying. Every single question so far had an image or a histological slide or this kind of thing happening, MRIs and CTs and whatnot. Every single one. And then the one question that didn't was actually arguably a slightly difficult question, but this was not so bad at all. And I went in depth about this question in the last video. So now today, part 2, we finish up the rest of block 1. Starting here with question number 26. So 26, it says a 52-year-old woman is admitted to the hospital because of shortness of breath due to malignant ascites and pleural effusion, right? This is a very big, hefty size question for NBME, and malignant ascites and pleural effusion. Alright, so far nothing crazy, nothing that we've never heard of. She has had ovarian cancer for 3 years. Treatment has included several courses of aggressive chemotherapy, including intraperitoneal chemotherapy and sclerotherapy for her recurrent pleural effusion. During prior hospitalizations, she has undergone debulking procedures. Okay. She has been discouraged by the ineffectiveness of therapy, and she feels emotionally and physically exhausted. Her primary care gynecologist suggests a palliative care consultation, but her gynecologic oncologist says he is absolutely opposed to giving up and is recommending referral for inclusion in a clinical trial. This disagreement between the two physicians is disconcerting to the patient. I love how they use these words that a lot of people might have never really heard of or used in everyday language, right? Disconcerting. Following thoracentesis and paracentesis, the patient calls her primary care internist to help address this conflict between the two physicians. Which of the following is the most appropriate next step for the internist to address the patient's concern? Okay, so you look through your answer choices. Now this is a real life scenario that can occur at any hospital, especially with a hospital that might be associated with clinical trials and research and whatnot. Very similar to the place I even work at right now, Montefiore Hospital in Bronx. They have clinical trials that they run within the hospital, and many medications that some patients can be put onto as long as they fit the criteria. So there's a disagreement and whatnot, different opinions among these doctors. What's the best thing to do? So look at your answer choices. A, contact a representative from the hospital risk management department. This is not a risk management. Risk management means that you have some kind of risk that this patient might be under, or some kind of risk that this patient might have actually taken on. And when you take on a risk, you then wait and see if the end result occurs, right, of the risk. Nothing like that has happened here, so that doesn't fit the criteria. Speak with the chair of the hospital ethics committee. This is not an ethical dilemma. This is more of what should we do next with this patient, right? We're coordinating care, essentially. What should we do next with this patient? Should we give up and put her under palliative care? Or should we keep trying hard and put her under clinical research trial medications? And the beautiful part of being on a clinical trial is that you don't have to pay for anything, right? The medication might be worth thousands and thousands of dollars, but for you, it would be free. As would any hospital visits or anything else like that. So, next answer choice says, speak with the two gynecologists to attempt to coordinate care. All right. That sounds pretty good. Refer the patient for pastoral counseling. Pastoral counseling would be like meeting a pastor, I guess, and that sounds like a religious thing that's really unnecessary and irrelevant to this case. Refer the patient for a psychiatric consultation to deal with her anxiety about the conflict. I mean, this is something you could do also, but it doesn't answer the question, right? Address the patient's concerns. Sending the patient off to a psychiatric consult to help her deal with her anxiety and whatever else she might be going through. Patients who've been dealing with cancer for long terms, like you see here, ovarian cancer for 3 years, They can often go into depression as well. They also feel like a burden to society, or at least a burden to their family. So, as choice E, I can see where they're coming up with it from. It's just, it doesn't answer the question. So to deal with this issue of everyone having differing opinions, the best thing to do is you all sit down and discuss it and figure out what's the best thing to do. I really appreciate that, Joseph. Thank you. Thank you very much. It's never a bother or disruption at all if you want to say anything. That's the reason I do these live. So if anyone has any questions or any kind of comment you want to make, you can go ahead and do so. Thank you. Thank you very much. All right, so that's number 26 right there. 27. There's no picture here, but again, another ethics type of question. So this one says a 65-year-old woman is being treated in the hospital for widely metastatic breast cancer, unresponsive to chemotherapy. Okay, so another cancer thing. She has never married and has no children or siblings. Throughout her illness, another woman she had introduced as my close friend has been with her during hospitalizations and office visits. The patient is moved to an inpatient hospice after she decides she wants no further curative therapy. So she's accepted that she's just going to die and stop trying. She and her friend appear very distressed when they read a sign outside the hospice unit that states only family members are permitted to stay after visiting hours. Her friends say, "We can't bear to be apart. It would be cruel to separate us now." Right, so they've voiced their thoughts. Which of the following responses by the physician is most appropriate? Now, ethics questions, my number one advice to everyone is always, when dealing with ethical theories and ethical things, right? Always assume that your patient, treat your patient in such a way that they are the multimillionaire that is your boss, right? So you would never say certain things to your boss. You would never say, for example, to your boss, it looks like you've been gaining weight. You would never say no to your boss. There are many things that you would never say to your boss. You would say it in a very specific manner if it was ever a thing. Right, so in that manner, it's like you always consider before saying something, would you say this to a millionaire person who is also your boss because you want to win their heart, you want to keep them happy, right? These are all things that you want to keep in mind with your patients too. You definitely want to win their heart, you want to keep them happy, you do not want to upset them. And the other thing is, it doesn't apply to this question, but in ethics questions, you also want to make sure that you always pick the answer choice that is most sensitive, right? You care about your patient. You want to make sure that they never feel any kind of maybe racism or something else that they can interpret as racism, any kind of indifference towards them, maybe because of where they're from or their gender, any other thing like that, right? You want to be super nice to them, super sensitive, very caring of what they're going through. So now here, there's a lot of things in this question. What could very well be possible, right, is that her and the other woman might actually be a lesbian couple, right? It could very well be possible. At the same time, they could just be extremely close, best of friends, basically, because it's likely that maybe the other woman also has never married and has no children or siblings, right? So they're just super close because they understand each other. Regardless of the case, that woman is the only thing this 65-year-old woman has that could be considered family, right? Now, what would be the most appropriate thing to do? So let's take a look at these answer choices. A, don't worry, I'll call you right away if something happens to your friend. Just leave your number with the nurses. First of all, no, I won't, because I will not have that much time to go ahead and, spend 5 to 10 minutes to go to a nurse and tell that nurse to call you and let you know that, hey, your friend, something happened. Either your friend died or your friend is going through some kind of event, blah, blah, blah. It's just not going to happen, right? That is not something that I want to take onto myself. That's an extra task for me to do. And also, doesn't address what she wants. She cannot bear to be apart. They cannot bear to be apart. This answer choice A pulls them apart. Okay. B, I'm sorry, but only family is allowed to stay with the patients in the hospital. You will have to leave after your 15 minutes are up. Again, I'm being mean because I'm going to go ahead and destroy what she just said, which is she cannot bear to be apart. And only family is allowed, sure, but this is the only family this patient has, right? The term family is not exactly solidly addressed in such scenarios. It doesn't mean that it has to be someone with the same last name or someone that shares the same blood type as you or anything like that, shares majority of their DNA with you. No, it just means family, right? Which means that your driver can't be around, your home caretaker can't be around, specific little things like that. And it also means that distant family can't be around, so you don't bring your whole crew, right? You don't want your husband, wife, and then, you know, uncles and aunts and everyone else. It's not like that, right? There's not that much space. So B also doesn't make sense. C says the two of you seem to have a very important relationship. Of course, you may stay together, right? And that seems like the perfect thing to say, and it would be a happy ending of a movie, and everything seems just right. No one's gonna be sad. No one's gonna be hurt. No one's gonna be upset. D. Visiting hours are posted outside. You are welcome during any of those times. I'm sorry, but an exception cannot be made in your case. Well, first of all, D and B are then now basically the same exact answer choice, right? B and D are the same exact answer choice. An exception cannot be made. Rules are rules, blah, blah, blah. So automatically you can consider D is wrong. And also because D, again, would hurt the patient, make them upset, is just not the right thing to do. One, the patient is about to die eventually. And the other friend is the only person that's going to be there. It's not like if I say yes to the friend, on top of that, there's going to be many other family coming and whatnot, right? The goal is to not have the hospital crowded. If this woman was just bringing a friend and this friend just wanted to stay there, but she does have children and siblings and a husband, then I would not let this friend stay, because if I let the friend stay and then the children visit too and the husband visits too and siblings visit too, it's going to be too many people visiting, too much traffic, too crowded. Right? There's a very critical reason they gave this sentence right here. E says, well, I guess we could bend the rules just this time, but if anyone asks, you're her sister. Does that sound okay? Now, this is a very cute trick answer choice, right? You would think that, oh, yeah, this is something I would say. I don't want to get in trouble. I don't want to get in trouble, right? We work our entire life to get our medical license, and then after getting it, we work the rest of our life to retain that medical license because we can get sued and lose it. This would be something that would keep me out of trouble, right? I'm going to tell this patient, sure, come on in, but if anyone asks, just say you're her sister. That would be considered lying, right? This is lying. This is definitely lying. You're her sister, that's a lie. This statement of, if someone asks, first of all, if someone asks, no one asks and just waits to hear your answer choice, waits to hear your response just verbally. They're going to ask for ID. And that ID is going to prove that she's not your sister. So, it's a bullshit answer choice, but it's a very cunning answer choice that you could pick if you're exhausted. But here the correct answer was just C. Alright, so ethics questions are ones you should never get wrong. And depending on how much practice you have and what skill set you have in terms of tackling ethics questions, what can often happen is that two answer choices or even more might all look correct to you. Right? Ethical questions are out there because of two big reasons. One, because it really messes up FMGs and IMGs, right? People who studied medicine in other countries, where the rules and ethics are very different. And then two, because here in America, if you do the wrong shit, you have the wrong ethics with the patient, you could get fired and your hospital can get sued and everyone loses a lot of money, right? So these are big deals. It's not just here. Ethics is not something just being taught just to make your life harder. That will be biochemistry. 25. A 34-year-old woman comes to the physician because she has been feeling weepy and overwhelmed since delivering a healthy male newborn 6 weeks ago. That sounds about right? This is something that we've heard of, right? Mood disorders after delivery, very common thing. She has had fatigue and irritability during this period, and she has had no interest in engaging in activities she used to enjoy prior to the birth of the baby. She also has had difficulty sleeping because she's always listening for sounds indicating that her baby is awake. She says, my husband doesn't help me at all with the baby. We argue all the time now. She then says, I feel guilty because I'm not enjoying my baby more. I don't know if I will be a good mother or not. Physical exam shows no abnormalities. Which of the following statements about the physician is most appropriate? Right, so this mother is coming to me with many concerns here. She's thinking about a lot of things. She just gave birth. She seems very stressed, and she seems like her life kind of is falling apart in her eyes, right? She sees her life falling apart. Relation with her husband, relation with the baby, development of the baby, blah, blah, blah. Things are not going too well. So I had to say something that's very caring, right? Very caring. I also have to concern myself with the possibility of this becoming a very dangerous type of postpartum depression, right? Because there's many types of that, and you have all of that listed out in first aid, the psychiatry, right? Where is it? Let me see. Yeah, peripartum mood disturbances, right? So you have maternal blues, which is really early, usually resolves within 10 days. Our patient is far beyond that. MDD with peripartum onset, which again can have issues that last more than 2 weeks, and this kind of fits where our patient might be. And then postpartum psychosis, which has risk factors including stuff that's really psychotic. And our patient doesn't seem to be at that point right now. Okay, so I'm thinking that, this patient might be at the MDD with peripartum onset point because of the 6-week time span that they gave. Right? She's been feeling like this for quite a while now. So you look at answer choices. Has it come as a surprise to you how hard parenting is? Many people feel that way. Now, this seems like I'm being condescending, a word that a lot of patients love to use, and I've been assaulted with that word myself. There was a rotation I was doing one time. My physician, the one that I was under, really loved me because I was so nice with all my patients. It was a family medicine rotation, part-time in the clinic and then part-time inpatient. Right now I was in the clinic, and when I was in the clinic it was a different doctor, and that doctor also was very happy with my work, very pleased with how I made sure I did everything with all my patients. There was this one patient that came. She needed help with, she was having murmurs, and I remember, no, not murmurs, sorry, she had a pacemaker. She had a pacemaker already, and she had questions about the pacemaker, and I answered everything she ever asked. Now, I don't vividly remember the exact dialogue we had, but what did happen was that when I was done, she stayed to talk to the doctor, so I was like, all right, sure, I'll send her over, and then I went to meet the next patient. And she said something to the doctor, after which, when I was done seeing the next patient, the doctor called me into her office just to tell me that I had to be careful with what I say, because that patient told me I came off condescending, right? And that was quite a piss off to me, but there's nothing you can do about it, and anger doesn't resolve any issues. But somehow I came off in such a way to that patient that she felt like I was putting her down, that I was making her look stupid or something like that, right? Condescending. You never want to be condescending. This would be something someone could take as condescending. Did you just find out how hard it is to be a parent? Yeah, that's not the right way to talk. So this is immediately not the right answer choice at all. B says, well, I'm going to skip B because that is the correct answer. So C says, I'm sure that you'll feel better soon. After all, look at your beautiful baby. This is not an answer choice that as a doctor I'm going to say. This is something I would say to someone as a friend if I wasn't a medical professional. Right? A friend might say this to another friend, like, you'll be alright, look at your baby, she's so beautiful, he's so cute, blah, blah, blah. Unnecessary, it doesn't resolve the issue. This patient might actually be having a serious medical emergency. Most new mothers feel this way, and sometimes it helps to see a therapist. Would you like me to give you a referral? Very much seems like a great answer choice to pick, right? This is a good answer choice. It's a very good answer choice. So let's keep this there, and then we of course still have to read the rest of them. E says, your relationship with your husband sounds strained. I don't blame you for being angry with him. It is not my job to give my 2 cents and opinions about how your relationship with your husband is going. That's not what a doctor does, right? So E falls out too, and then the only answer we left is B. I'm concerned about how bad you've been feeling lately. Have you had any thoughts about death or wanting to be dead, right? So now you're stuck between B and D, and the only way to pick between the two is to know the differences between these things, right? That's the only way to really know what the difference between the two things is. So I went on to write, postpartum blues usually resolve within 10 days. MDD with peripartum onset lasts more than 2 weeks. This is what the patient is exhibiting. Postpartum psychosis involves thought about harming the baby yourself and requires hospitalization and atypical antipsychotics. The only good answer is the one that is gauging how far her peripartum disturbance may have gone. See, the reason we asked this answer choice B, right, is because you could see how MDD with peripartum onset, it lasts more than 2 weeks, which is a minimum, not a maximum. We don't know how long it lasts though. It could last for more than 2 weeks, which means 3, 4, 5, 6, 7, 8, and so on. Postpartum psychosis also lasts more than 2 weeks, and it can occur at any time. So we need to see, does she have MDD or does she have postpartum psychosis? And the only real way to figure that out is to find out if she has thoughts of harming the baby or self. Right? So by asking this question, have you had any thoughts about harming yourself or harming the baby by any chance, And then she'll be like, yeah, there was one time I thought about, killing my baby because I was so stressed out and everything's been so bad ever since the baby came. I'm not happy with my husband. I'm not happy with my life. Once she makes that statement, she would qualify to be in postpartum psychosis, at which point we would first keep her apart from the baby and then start treating her. Right? Hospitalization and initiation of atypical antipsychotics, because we can't send them home where she's just going to go kill the baby. Right? So that's how this question became a very difficult question. That was the only thing that made this question difficult. Otherwise, D seems like a very feasible answer choice, right? Send her to a therapist. But D would be the next step, right? If I ask question B and then she says, no, I've never thought about death or killing my baby, then I'll be like, all right, let's send you to a therapist, because now I know for sure she has MDD, where the treatment is just CBT and SSRI. So, you can send her to a therapist also for the MDD part, where she'll get the CBT, cognitive behavioral therapy, and then she'll be all right. So, very strong question, very hard question, just because both B and D are strong answer choices. So not only did it test you on ethics, it also tested you on the psychiatry of knowing peripartum blues. Number 11 says, this is number 29, says, a 75-year-old man with dementia Alzheimer type is brought to the hospital by his wife because of cough, difficulty breathing, and agitation that began after he ate breakfast 2 hours ago. He has been a resident of a skilled nursing care facility for 7 years. His wife visits the facility daily to feed him his midday meals. His 2 adult children visit him several times weekly. His wife mentions that the patient has been coughing during his meals for several weeks. He also has been taking longer to finish even smaller portions of food. Results of imaging studies are consistent with aspiration pneumonia with a developing compromised swallowing function. His medical records show no advance directives, and speaking with the patient's family, it is most appropriate for the physician to address the issue of a feeding tube in which of the following manners. Right? So there's no advance directive, and it doesn't look like I can really ask the patient what the patient wants, right? Because the patient's not doing well, and he's very old, and he has Alzheimer. So what should I consider before I go to his family members and be like, all right, we're going to need to do a feeding tube? So I'm going to skip A because that is the correct answer. So the next one, explain that a feeding tube is difficult to monitor and may not prevent aspiration. Why? See, now that doesn't make any sense to say, because we would want to put him on a feeding tube, and it kind of does prevent aspiration. Not entirely, but it helps. It definitely helps. It would be something that can help. So, yeah, that doesn't fit at all. C, follow only the wishes of the wife. Since he doesn't have an advance directive that says so, to follow only the wishes of the wife, we don't do that. Okay. D, help the adult children encourage the wife to start a gradual withdrawal from the patient because he's about to die soon. That would be unnecessary and stupid also, right? It's not my job to tell, hey man, listen, you gotta go tell your mom to, start distancing herself from her dad, from her husband, because your dad's about to die. That sounds so stupid to do. Like, just imagine doing that. It's not logical or ethical. E says recommend a tube because feeding will be more efficient and prevent starvation. Very cunning answer choice. Very cunning answer choice. However, A says encourage the family to come to a consensus based on their perception of the patient's wishes. And that is something you always do with someone who doesn't have an advance directive. I'm sure you've all seen many other questions where, here E seems very pleasing, very cunning, but that's why these ethics questions seem so hard, right? Another answer choice could look like something doable, something feasible, something that's totally logical, but it's just not the correct protocol. It's not the correct protocol. That isn't what you actually do. What you actually do is always go by what everyone says is what the patient would have wanted. If nothing is written, you wait to hear everyone's story on this, and then you make sure they're all saying it in front of each other so no one's making it up. And if they all say the same thing, then you know that is how the patient lived his life, and that's how the patient wanted his life to end, and you go follow that, right? This question is twofold. You must know the decision-making hierarchy and also consider autonomy. Making recommendations for certain treatments is wrong because it violates autonomy and informed consent, right? As a doctor, it's not my job to come tell you, hey man, this is what you should definitely do. I have to give you recommendations if you ask me, right? As a patient, if you come ask me like, hey, what do you think? What do you think would be better, doctor? Should I do this or that? But it's not exactly my job to come be like, all right, this is what I say you guys should do, right? Autonomy doesn't exactly work like that. And on top of that, I can't make that conversation directly with the patient. So it would be stupid of me to have that conversation with the rest of the family, right? At that point, I might as well not even ask them anything. Physicians should simply explain the RBAs of all treatment options and allow the family to decide what is best based on informed consent and their perception of the patient's wishes. If the patient was alive, I would just talk to the patient directly and be like, all right, so this is what I think we should do, where I would give my 2 cents as a doctor, and then let him decide what he thinks is best for him, right? Priority of surrogates is spouse, adult children, parents, and siblings, which is why they have design choice follow only the wishes of the wife. This would be really dumb. Imagine a scenario where the wife is standing there, a couple of his kids are standing there, he's knocked out, has Alzheimer's, is not responsive, whatever. And I come and I'm like, all right, wife, what do you think we should do? And the kids are going to be like, what the fuck? We want to be able to say something too. There's no advance directive that specifically says I have to listen to the wife, right? Completely illogical to listen just to the wife. If a consensus cannot be made, then the wife would have first say in the decision, or things can be moved to the ethics committee. Therefore, encouraging the family to decide according to the wishes of the patient would be a better first step, especially if the wishes of the wife is contrary to that of the patient, right? Maybe the wife hates the husband. But if the kids are like, no, my mom hated dad, the truth of the matter is we should not do it too, let him die, something like that, then this would be something that we would have to escalate, right? Bring it to the ethics committee. Vanessa says, I would not have chosen A because it says perception, almost like they're not sure what he would have wanted. Yeah, well, the reason they use the word perception, right, is because theoretically they're not sure what he would have wanted. They aren't, because no one knows what his will is, right? Like, for example, if my mom or dad were to die, I wouldn't entirely know whether or not they would want certain things, right? I wouldn't know entirely, because these are conversations you don't necessarily have. But depending on what you do know about your parents, you can make up a perception of what you think your parents would have wanted. Whether they would want the feeding tube or not, whether they would want resuscitation or not, and so on, right? And all of that really comes down to making sure that everyone on the table has the same thoughts. The mother or the wife and the kids, right? They should all have the same ideology about this one man, because we're all talking about the same man, right? So very important to watch out for stuff like this. Very common scenario. This is not entirely made up either. This is a real scenario. Something like this would really happen, right? And what you would do is you would tell the family to come to a consensus together, figure out what they think it would be best for this patient, because there's no advance directive. If there was, we wouldn't need to ask anyone. If there was an advance directive, we would do what it says on the paper that this man already signed, right? That's it. Even if the wife was like, no, we shouldn't do that. We shouldn't do that. That's not what he wanted, blah, blah, blah. Like, nah, man, looks like he wanted that because he definitely signed this paper. Done. All right. So I can totally see the confusion though, and questions like this can be and are specifically designed to be confusing, both to take out IMGs, like I said before, and people who just haven't had the experience, right? Even if you went to med school in America, you just might not have had the experience, and it's very important to have these experiences where you finally start seeing how this is actually handled. All right. So good question. Again, very good question. Number 30, a 25-year-old woman has a 3-week history of bleeding gums while brushing her teeth and easy bruising. So this is something hematology related. She appears anxious but alert, no lymphadenopathy or organomegaly. Irregular bruises are noted on her legs, thighs, and arms. Numerous petechiae are noted. So as soon as you know something about petechiae, you know this is a platelet problem immediately, right? Originally, I would have thought maybe this is von Willebrand disease because that occurs to women, whereas hemophilias occur in men. As far as step 1 is concerned, just because of the genetic aspect of these things, right? X-linked versus autosomal dominant can occur in both genders, but usually in step 1 is a female. But petechiae makes it a platelet issue, so now I'm down to that list of platelet things, Glanzmann and all of that. Numerous petechiae are noted on the left arm, distal to where the blood pressure cuff is used. She delivered a healthy child 9 months ago and is not taking any medication except for an oral contraceptive. So there's no reason something should be wrong is what they're basically saying. The only big event in this patient's history is delivery 9 months ago. Hemoglobin 12.5, a little on the lower end. Leukocyte count 8,500. Differentials is fine. Erythrocyte morphology is fine. Platelets are rare but large, which is pretty diagnostic right there. And then urinalysis is fine too. Which of the following is the most likely cause of a condition? So autoantibodies against platelet glycoproteins, right? Page 415. So let's take a look at this. This is actually a very important one. I talk about this all the time because this is actually step 1's favorite platelet disorder to pick on. So that would be, that will be this one right here, and this is a very common one. I really love this answer choice, ITP, because it's almost always the correct answer. The reason step 1 likes ITP is because it can occur to anyone for no fucking reason whatsoever, right? And they tell you that. Maybe idiopathic. Anything that may be idiopathic, step 1 loves it, right? Because they can give you a scenario where a patient comes in perfectly fine, just like you, but has a petechial rash out of nowhere. Right, that is ITP. One of the things that might have actually initiated it might have been due to the delivery. Could be something related to the delivery she had. Something went off, right? So what's wrong in this patient? There's a destruction of the platelets in the spleen. She has antibodies against G2B3A, right? GP2B3A, and you're gonna find on labs a lot of megakaryocytes on the bone marrow biopsy, a decrease in platelet count. So that's basically the easiest way to get stuff like that down. The other thing is TTP, right? TTP is the other one. You start seeing von Willebrand factor multimers, right? They'll describe it as big von Willebrand factor multimers because you lost the ability to have the metalloprotease, von Willebrand factor metalloprotease. You don't have it, Adam TS13 deficiency. Right? So you don't break down your von Willebrand factor multimers, and you have more platelet adhesion and aggregation, a bunch of stuff like that. For our patient, actually, it could also be TTP. We don't entirely know what's wrong with her, right? This one, for her, it could also be TTP as well, to be honest. Right? Do they have another answer choice that says TTP? Viral suppression, widespread damage, acquired antibodies against platelet antigen P1AT. That's, I don't know what that is. Folic acid deficiency is irrelevant. Viral suppression, yeah. This patient could also be TTP as well, I believe, but we're not given enough information to pick that. Either way, the correct answer would be autoantibodies against platelet glycoproteins, right? And since this is the correct answer, the glycoprotein is GP, which is GP2B3A. That is a glycoprotein, right? So you lose this, you start having a decrease in actual platelets. And when you lose platelets, you get petechial rashes. So anytime you see petechiae, you know this is a platelet problem. That's it. That was the only one that was about platelet. What is this thing? Antibodies against platelet antigen. Let me check that real quick. Antibodies against platelet antigen P1AT or A1? P1A1. P1A1. Fetal and neonatal alloimmune thrombocytopenia is caused by maternal antibodies against alloantigens on fetal platelets. So this is neonatal. This first one here is neonatal alloimmune thrombocytopenia. Right. Which could have been a thing, but she delivered 9 months ago. Wow, that's actually pretty cool that this could actually be a possible answer choice. Had you actually been... So this is another thing that happens with people that study for step 1. Some people study too much, right? And that is actually a thing where at some point you could know a lot more than you actually needed to know. And had you known about neonatal alloimmune thrombocytopenia, you would be so inclined to pick cancer choice A just because she did deliver pretty recently. But that was pretty irrelevant. It wasn't that at all. Her answer, it is, let me just check on the forum too. Autoantibodies. Yeah, I guess platelet glycoproteins was the correct answer. Yeah. So yeah, but neonatal alloimmune thrombocytopenia, very interesting thing. Choice A refers to neonatal alloimmune thrombocytopenia. But that's not really relevant to her, and you can check more about that on Wikipedia if you're interested. Okay, so another big question with the table and all that shit. So let's see what's happening here. A 34-year-old woman is brought to the emergency department 30 minutes after she fell unconscious on a downtown sidewalk of apparent alcohol intoxication. Okay, so she was drunk and she fell. At the scene, her companion tells the emergency medical technician that the patient regularly ingests alcoholic beverages but can usually hold her liquor better, so she doesn't always fall. On arrival, she's intubated. Physical exam shows no other abnormalities except for mild cyanosis. And then they give you the labs. All right, high chloride, sodium. Okay, potassium's high. Bicarb 10, which is low. Right. Arterial blood gas analysis on room air shows a low pH, PCO2 23, PO2 of 78. Right. So acid base. Now it's on the cheat sheet as well. But there's two things that you should be able to draw as soon as you need to. Like this is supposedly part of your studying, right? So one thing you should be able to draw is this table that kind of lists out all the different types of metabolic acidosis versus respiratory acidosis and so on, where this upper axis here is actually supposed to be your CO2. Okay, CO2, and then this axis here would just be your pH. I can't really write neatly with pen mouse, especially right now because I'm not really feeling anything. I'm tired. And the left axis, that's so ugly. And the left axis would just be, so let me just show you the table because I don't have the energy for this right now. The left axis would be your bicarb levels, acid base physiology. This table, right? This is what I'm trying to draw right there. Because you see your bicarb on the left y-axis, your pH on the x-axis, which goes from 7 to 7.8, and then on this upper thing over here, this extra axis, this is your PCO2, right? Now this is really cool because this is actually really easy to draw, and what you notice, there's a normal level, right? So there's a normal level right here, where the pH normally should be 7.35, the normal HCO3 should be 24, and the normal CO2 should be about 40. Okay, this is how you make the graph when you draw it, and I put it on the new cheat sheet that I've been developing. I haven't posted it yet. And once you do this thing, right, you write all of these things, all the different parts that are here. So on this this area right here, you put resp, or I write it as R-alk, respiratory alkalosis, right? Acute respiratory alkalosis or chronic respiratory alkalosis. So I just put it as AR-alk, right? On the actual cheat sheet. Whereas over here it would be CR, chronic respiratory alk. That's all that goes on this side. The reason doing this is really nice is because once you put this table together, right, you can start seeing where everything is, and you can really immediately start figuring out what's wrong with the patient. Now, on step 1, questions hopefully will be pretty easy when it comes to your acid-base physiology, right? Memorizing this table is cake too, and this is also on the cheat sheet. You don't need this column. You know what the pH is. If we're talking about metabolic acidosis, pH is low. And if we're talking about metabolic alkalosis or respiratory alkalosis, the pH is high. So you don't really need this column over here. What you do need are these two columns. And there's a very cool trend. In metabolic acidosis, both things are low, right? Whereas in respiratory acidosis, you see how both things are high? And what's the difference between them? What's the difference here? They're both acidosis. Right? So that's the thing. Like you would have for metabolic acidosis, all 3 arrows are pointing downwards. Right? In respiratory acidosis, these guys are pointing up. Right? There's a really interesting trend like that. It's not something you can forget. Same thing with metabolic alkalosis. In metabolic alkalosis, all the arrows are pointing up. Right? So easy to draw. Metabolic acidosis all point down. Metabolic alkalosis, they all point up. And then when it comes to the respiratory stuff, they're backwards. So acidosis is still pointing down, of course, because pH is low, but the other two are up. Respiratory alkalosis still pointing up, of course, because alkalosis means pH is high, but the other two are pointing down. This graph is something you can easily reproduce, and then you just go tackle questions. The last thing to remember is that it's easier to hyperventilate. You can just start doing that immediately using your muscles. So hyperventilation is an immediate compensation for metabolic derangements. But fixing renal reabsorption is not something you can directly control actively by yourself. That's something your body does. So that metabolic renal compensation is delayed. It takes time. And since it's delayed, there's a difference, right? That's why you have acute respiratory acidosis, where the bicarb level is pretty much, you see how the acute stuff, in the acute stuff, your bicarb levels are pretty much within the normal range of 20 to 28, because they have not been altered yet to fix the compensation. Right now, if it's acute respiratory acidosis, you need to save bicarb, which is an alkaline thing, save bicarb to go from here to here, right, to make it a little more normal looking. Now, of course, you can never save enough bicarb to fix the acidosis aspect of things, but you do become a little closer towards normal, right? You see the shift is towards the right, which is towards normal pH, right? Left and right means pH shifting. Same thing happens with the alkalosis part 2. Very easy stuff. This just takes time. That's all it is. Once you spend enough time mastering this, it becomes super easy to tackle these questions. And then the question we have here was slightly difficult because it's not one issue. Look at the answer choices. You have mixture, right? Do you have metabolic acidosis with an increased anion gap, or do you have mixed respiratory acidosis, right? Do you have normal anion gap? What's happening here? You have to pick one over the other. You also get other answer choices. There was another question in one NBME where all the answer choices were some kind of mixture, and it was very difficult. So here, right, of course you should always calculate the anion gap. Anion gap is very easy to calculate. It's positive minus the negatives, right? So the only positive you really care about is sodium, and the negatives are your chloride and bicarb, right? And they tell you that in the book as well. Your anion gap right here, right? Sodium minus the sum of your negatives, the chloride and the bicarb. So you do that here, you get an anion gap of 25. Normal anion gap should be about 12. Right? This thing, the normal anion gap, if it's more than 12, then that's a problem. Between 8 to 12 is normal. More than 12 puts you under the mud piles area, and we expect that because if you remember mud piles, then you remember M is methanol and E is ethylene glycol. These are all things that are very similar to alcohol. That's basically all you're wondering there, right? Methanol specifically is basically alcohol. So we expect the anion gap to be high, and we know that this guy has acidosis because the pH is low. So technically speaking, if you've done your studying and you know alcohol causes metabolic acidosis with increased anion gap, you would just pick B and move on. Other questions can require more, right? There can be questions that could require you to go ahead and do, for example, this business here from NBME 22. Right? NBME 22 had a question where you had to use the Winter's formula to figure out what the baby had. And the baby in this question, the newborn, had respiratory acidosis and metabolic acidosis, both. Right? And how you would figure that out was based off of the Winter's formula. So this is something that the Winter's formula is very easy to remember, and it's also on the cheat sheet. You should put it there until you've got it down. But regardless, it is something that's totally tackleable. And this was a not so bad of a question. Right? But memorize, when you're studying acid-base physiology, memorize the fact that everything in metabolic acidosis and alkalosis points the same way. Memorize how to draw this graph, and that will put you at a whole different level with acid-base physiology questions. Whole different level, right? And then, of course, know your Winter's formula, how it's used, what it means. And then I have a bunch of notes here that I've talked about already when we did renal acid-base physiology. It had its own entire video, where remembering the connections of other things and how they present was also critical, because questions will always try to combine things. Alright, 32. A healthy 8-year-old boy is brought to the physician by his parents because of a long history of disruptive behavior at school and poor academic performance. During class, he talks out of turn, wanders around the room, and pesters classmates. He is easily distracted and cannot keep his attention on a topic very long. His homework is sloppy and usually incomplete. He often explains that he leaves segments of assignments undone because he just didn't notice them. He's had similar problems since kindergarten. He has normal developmental milestones. He is bright and cheerful and has a caring family. A drug with which of the following actions is most likely to be useful for this patient? Right, so for a second, you might have actually thought he didn't even need a drug, right? Because things are looking just fine. But what he's doing is something that, this is how I like to think about it. If there was an adult that was doing the same kind of stuff, we would definitely think there's a problem, right? But let's forget some of the things this guy is doing. So let's take out wanders around the classroom, pesters classmates, because these are not things that an adult will be doing. Talking out of turn, right? Let's just take those out. But then there's something here. He says that he can't pay attention for long times, and his homework is sloppy, which I can totally see an adult doing, usually incomplete. And then this adult might even tell you, oh, I didn't see that question. Right? Maybe some question had 3 parts to it, and he missed part C of the question. If an adult did something like that, I would look at him and be like, what are you, man? Are you 8? Right? Because this is an 8-year-old. So the behavior this kid is presenting with is theoretically pretty normal, right? The only thing is he needs help truly focusing, because he's not lying, and nor is he being a bad person on purpose or anything like that. He just needs help focusing, and that's something even we adults use, right? This is something called an amphetamine, right? When you take amphetamines, you start focusing better, and then you stop taking amphetamine, and eventually you are better at this. So here the answer was just straight up C. Right? Just put C. Discusses childhood and early onset disorders. Excitatory amino acids refers to glutamate, while biogenic apparently refers to tyrosine, or any of tyrosine derivatives, the precursor amino acid to dopamine and norepinephrine. Amphetamines use the norepinephrine transporter to enter the presynaptic terminal, where they utilize the vesicular monoamine transporter to enter neurosecretory vesicles. Right? This displaces norepinephrine from the vesicles. Once norepinephrine reaches a concentration threshold within the presynaptic terminal, the action of NET is reversed and norepinephrine is expelled into the synaptic cleft. This child most likely has ADHD, which even adults can have. And amphetamines are the treatment for most of these disorders, the childhood and early onset disorders, or ADHD-related disorders. Okay, not a difficult question, but they definitely presented it in a very difficult way with the answer choices they picked. But from reading the question, you should have been able to figure out that the kid just has ADHD. He's just not paying attention. Right, so page 6, what did I put? I put a dash by mistake. What would the dash be? 603? Let me see. Because 603. Childhood and early onset disorders. Yeah, let me just change that real quick. Oh, I think oh, yeah, I have it. Hold on. Yeah, my bad. I knew I was going to do this too. I had the key. Page 603. So, childhood and early onset disorders, when you look at them, there's a bunch of these things here, right? Some of these are very specific and very obviously, like, problematic. For example, oppositional defiant disorder is very problematic. Conduct disorder is very problematic. Autism spectrum is a very common thing. Our guy just has ADHD, right? Where there's a bunch of medications that are listed here, but stimulants are the main thing. Methylphenidate or any other amphetamine that would be appropriate. 33. A 61-year-old woman is brought to the physician by her 62-year-old husband because of a 9-month history of increasing forgetfulness. Her husband says, I'm worried because she forgets about dinner on the stove and it ends up burned. Once she even left the bathtub running and it overflowed and flooded the bathroom, which is very disturbing, very problematic. He adds that she had always been a meticulous gardener, but now the flower beds have become uneven, with some areas flourishing and others seemingly untouched. Physical exam shows no abnormalities. During the mental status exam, the patient is pleasant and cooperative. She describes her mood as good. She admits to being forgetful and feels bad about upsetting her husband and burning the food so often. Her mini mental state exam score is 22 out of 30, which could be pretty irrelevant to you. If you've never done a mini mental status exam test, a questionnaire with your patient, then you don't know if 22 out of 30 is satisfactory enough or not. right? It seems like such a simple number, like, hey man, I got a 22 out of 30, let me pass, right? Which of the following is the most appropriate pharmacotherapy? So we know for sure that she's definitely got some level of forgetfulness, right? It seems like with her age being 61, she could have mild Alzheimer's. It might not be terrible Alzheimer's. She could have mild Alzheimer's, though it's definitely become problematic within the household. So, given that she could have Alzheimer's, donepezil seems like the only medication we would put her on. All these other medications make no sense. Fluoxetine is an SSRI. Imipramine has so many side effects. Melatonin is irrelevant. She's not just trying to sleep. Risperidone is an antipsychotic that she doesn't need. Vitamin B1 would be for an alcoholic, right? And then you would give the glucose after that. And vitamin E deficiency would present with something similar to B12 deficiency, but also with hemolytic anemia. She doesn't have any of that. All right, so donepezil would be the perfect answer choice. She has Alzheimer's. That's it. There's not much to think about there. This is something that NBME loves talking about, only because it's not really taught much. And I know I'm recently doing respiratory videos, and I'm not done with them yet because I just haven't had much time. But PEEP is something I do plan on talking about there. It becomes much more obvious once you truly understand what I've been talking about in the latest respiratory videos, where I talked about, in respiratory physiology, I talked about how we breathe, what happens in intrapleural pressure, what happens within the lung itself. And once you understand the whole physiology of how the lung works, it's much more obvious. So Rose Gold is asking, how about dementia? You can use risperidone for dementia. How do you differentiate Alzheimer's? Right. So the main thing was the mini mental state exam for differentiating that. See, if you look at the mini mental examination, let me tell you. That was a good question because I forgot to come back to the mini mental state exam to show you guys what it looks like. Right, so this is the mini mental status exam. All right, something like this. It's basically a questionnaire, right, where you would ask the patient some basic questions. What is today's date? You know, what is the month? Blah blah blah. What season is it? Right. If you're not completely dementia, right? If you have dementia, you might not remember some of these earlier things. Orientation to time, orientation to place, immediate recall, right? These are things I would do. Ask if you made tests her memory, and then tell them 3 different things. And this is saying, just say ball, flag, and tree. Clearly and slowly, about 1 second for each. After you have said all 3 words, ask him or her to repeat them. The first repetition determines the score, right? And that's just stuff you keep doing. You do this entire thing, you work it all out, and then you score it. Right, now, they tell you the individual can receive a maximum score of 30 points. A score below 20 indicates cognitive impairment, which would be more so likely for dementia. All right? So that's why I was saying that you might not know if 22 out of 30 is something that's considered good or bad. The 22 out of 30 was a good thing. She passed, and she doesn't have dementia. It seems that she might just have early onset Alzheimer's. Has she gotten a really low score, like a 12 or a 9, then we would think that, even at that point actually, for this patient especially, we would think that she just has excessive, really, really bad Alzheimer's and still give her donepezil. There's a very big criteria for dementia too. Let's take a look at what dementia looks like, because progression of that, progression is a big differentiating factor for these things, right? Because dementia is very progressive and gets worse over time really, really quickly. And you often compare that to delirium, right? So looking at dementia, chronic progressive decline in mental status, common symptoms of gradual memory loss and language deficits, usually irreversible. And you have to rule out other differentials, right? So dementia has many things, and some etiologies can be Alzheimer's, vascular, frontotemporal, Lewy body, Creutzfeldt-Jakob. Now, one of the things I had mentioned when people asked me was, why is NBME so hard for me? I'm doing well in UWorld. UWorld's trying to teach you. NBME is not teaching you, it's testing you, and they won't give you maximum information. And on top of that, they also test you on the concept of what is most common, right? What is most common, and most common for such a scenario where they gave what's happening with this patient, the whole description of everything that's wrong with her, it's most likely she just has Alzheimer's, right? And also keep in mind, risperidone is I like to say risperidone is risky. It's a very problematic medication. You really don't want to give that to just anyone. And you do want to just keep it to basically, using it for like, why is this page not loading anything? Interesting. Okay. That tab did not open to pharmacology. Where is, okay, right here. Typical, atypical, right? Risperidone. Where is it? Right here. Right. You want to think of this mainly for schizophrenia. So you don't want to try giving something like this to someone who just has dementia per se. It's a very problematic medication. Causes many more side effects than just what's over here. When I did my psych rotations, I saw people even get nightmares. People get all kinds of like sleeping disorders. Can't do anything correctly. It's very, very disturbing. Very disturbing. So you wouldn't pick that for this patient. This is just a patient with Alzheimer's, and that's it. Alright, so now this question over here. 45-year-old woman is brought to the emergency department 45 minutes after she was involved in a motor vehicle collision. What is this? Okay. YouTube is not receiving enough video to maintain smooth streaming. As such, viewers will experience buffering. I can't do anything about that. I'm in America. If Wi-Fi can't be good here, it can't be good anywhere else. Alright, so 45-year-old woman is brought to the emergency department 45 minutes after she was involved in a motor vehicle collision. Temperature is 99.3 F, pulse is 100 per minute, respiration is at 28 per minute and shallow, and blood pressure is pretty low, 105/74. Physical exam shows numerous lower extremity lacerations. There are multiple fractures that require deep sedation before treatment because of pain. She's intubated with a cuffed endotracheal tube and mechanically ventilated with supplemental oxygen. The patient's ventilator settings are adjusted to deliver a tidal volume of 400 milliliters and 18 breaths per minute, and a positive end expiratory pressure of 10 is applied. Application of PEEP will most likely prevent which of the following complications in this patient. Now you look at all the complications, and the first thing you should do is what is a possible complication that this patient can undergo, and then I'll think about preventing it, right? And the only thing that can really happen to this patient is atelectasis. Her lung basically, the alveoli just blowing up. Positive end expiratory pressure is there to save her from atelectasis from happening. She will not develop cardiogenic edema. She doesn't have heart problems. She's not going to have pleural effusion. It's not that her heart is causing things to back up. She's not going to have pulmonary hypertension. Again, slightly relevant to the heart, not something that she's dealing with. She definitely is not going to have a tension pneumothorax. That's not what we're preventing with the PEEP. And tracheal dissection is irrelevant too. This was a very easy question disguised to be a very hard question. That's what they kind of did here. Applying PEEP increases alveolar pressure and alveolar volume. That's something you need to know about PEEP. Once you understand that, that also kind of helps. The increased lung volume increases the surface area by reopening and stabilizing collapsed or unstable alveoli. This splinting or propping open of the alveoli with positive pressure improves the ventilation perfusion match, reducing the shunt effect. All right, so very simple concept, but very important concept, right? Or you could say very complicated concept, but regardless, it's a very important concept. You want to make sure you spend some time really truly understanding that, so that you can pick such an answer choice. NBME has had other answer choices where they kind of picked, where they wanted you to calculate PEEP, right? And that's a whole different thing that I really hope they won't do again, because you don't need to be able to calculate PEEP at all. 35. An investigator is studying the regulation of pulmonary lymphatic flow using an animal model. Catheters are implanted in the femoral vein, pulmonary artery, and main lymphatic vessel, draining the lungs in anesthetized, intubated, mechanically ventilated animals. Drugs may be injected directly into the pulmonary artery catheter, and inspired gas mixture is altered at the ventilator. timed collection of lymph from the catheters is used to calculate lymphatic flow. Which of the following interventions will most likely increase the flow of pulmonary lymph in these animals? So anything that would increase pulmonary lymph flow, right? Increase the flow of pulmonary lymph in these animals. And then you look at all your answer choices. Administration of endothelin 1, administration of phenylephrine, decreasing inspired oxygen concentration, increasing inspired carbon dioxide concentration, IV infusion of normal saline for 5 minutes, IV infusion of 20% albumin, which is just protein, for 5 minutes. What is going to help? So this is a slightly difficult question, or I would even say it's a very hard question. But understanding lymphatic flow was a pretty important thing. What would actually increase lymphatic flow? So here the answer was E, IV infusion of 0.9% saline for 5 minutes. Expanding the interstitial fluid volume exerts radial tension on the anchoring filaments attached to the endothelial cells and initial lymphatics, which increases luminal volume. So basically when you expand interstitial fluid volume, the lumen gets wider and more fluid is going to sit in there. This creates a small pressure difference that drives interstitial fluid into the lymphatic vessels. In addition, increased luminal diameter reduces the resistance to lymphatic flow. Interstitial pressure would increase with IV saline. The other answer choices are just completely irrelevant. None of the other answer choices change the makeup, right, the constituents of the actual serum versus, protein amounts. The two things that are important for that one equation that I call the Cetacci equation. Let me find it for you guys real quick. So I think it's right here. Yeah. All right, so I memorized this equation when I was first starting to study using Cetacci, which is a type of chlamydia. Right, but it helped me remember the PCI, which is this: PC minus PI and pi C minus pi I, right? This entire equation, taking a difference of all of these things, PC minus PI, subtracted from pi C minus pi I, doing this tells you what's happening with all these different things, right? And JV is your net fluid flow, right? Which is how you calculate this entire thing. This entire thing is your net fluid flow. So if we want to have, as they asked in this question, which of the following would increase the flow of pulmonary lymph in these animals, to do so, right, you would just put in normal saline. That's it. If you do any of these other things, you will change other things as depicted by the arrows in this diagram. And this is something you could spend some time on for sure, but it's not really something that's that high yield. Not that high yield. I would make sure I understand the basic ones that they explain right here. Like right here, capillary pressure increases in heart failure. You have more capillary permeability with infections and burns. Right? Higher colloid pressure if you have lymphatic blockage, which is exactly what colloid or protein pressure is. And decreased plasma proteins or decreased oncotic pressure if you have liver failure, right? Or any renal failure where you're losing proteins in your urine, stuff like that, nephrotic syndrome, right? So basic things like that. And then based off of that, whatever changes in the equation will lead to different things happening, right? Not so bad at all. But here the answer choices were just all completely irrelevant except for E. E was the only one that was relevant, right? So to increasing lymph flow. Endothelin 1 is relevant to the lung, but not exactly for lymph flow. It's more for blood vessels. 55-year-old woman comes to the physician because of a 6-month history of bone pain. She has a 20-year history of type 2 diabetes and has been receiving hemodialysis for the past 5 years. She cannot recall which medications she's taking, but she admits that she often forgets to take all of them. Physical exam shows no abnormalities. Serum studies show a calcium of 8.2. Creatinine is off the charts. Her kidney is pretty much gone. Phosphorus is 8. Alkaline phos 180. This patient's bone pain is most likely caused by which of the following changes in serum concentration, right? So it looks like her bone pain might be related to the kidney not being able to do much, and that's renal osteodystrophy. So look at all the answer choices, figure out where the kidney would not work, right? And this patient, the only issue she could have is she could have high PTH because her PTH that she's making is not working. That's it. She would not have decreased 25 hydroxycholecalciferol. That one comes from, you have to remember where all these guys come from. And NBME actually likes picking on that. It's a pretty silly little thing NBME enjoys picking on. They love picking on dumb things. It's a big fact, right? So you can see how 25 hydroxyvitamin D comes from the kidney. Sorry, from the liver, right? So that's not the one this patient would be missing. This patient would have decreased amounts of 125 dihydroxyvitamin D, right? And that's not one of your answer choices. But she would have decreased 125 dihydroxy because the kidney is not working. So A is not a correct answer choice. Decreased parathyroid hormone, no, she's going to have increased parathyroid hormone. And then you see that in E and you pick that and you move on. Right? This patient has secondary hyperparathyroidism due to chronic renal failure. Creatinine level is the giveaway for that answer choice. Chronic kidney failure, renal failure. Her bone pain is due to renal osteodystrophy. The patient will have more 25-hydroxycholecalciferol because the liver's 25-hydroxylase will be functional, but the kidney's 1-alpha-hydroxylase will not work. And this is not, but regardless, this is not the direct cause of her pain, right? Because you could theoretically pick answer choice D also, right? You could pick D would probably be true. You would have a lot of 25-hydroxylase activity, a lot of 25-hydroxyvitamin D, and none of this is going to become 125. So 25-hydroxyvitamin D might be higher in this patient compared to normal. It might not even be higher because most people don't even have any vitamin D. It's a very sucky thing that's very true about people that avoid sunlight or come from a culture where it's just not a common thing to sunbathe or whatever. D could be a correct answer or a true answer, but it wouldn't answer the question. It's not a correct answer. Right? It's not going to be the reason for this patient's bone pain. 37. A 35-year-old man is brought to the emergency department because of a 2-hour history of severe fatigue and dizziness. He has had profuse watery diarrhea for 8 hours despite a lack of oral intake. Right? So he's not eating anything, he's still getting diarrhea. Recently returned from a medical relief trip to a remote village in the Honduras. Temperature is 98 F, pulse is 122 per minute. Blood pressure is 90/50. Physical exam shows dry skin and decreased capillary refill. Test of the stool for occult blood is negative. The stool is gray and turbid. A gram stain of the stool shows predominant gram-negative comma-shaped, right, or curved bacteria, no erythrocytes or leukocytes. Which of the following best describes the mechanism of toxin that caused these findings? A second-degree question. First degree would be figure out what is the bug in the first place. So the only curved bacteria this could really be with the watery diarrhea would just be Vibrio cholerae, right? The gram-negative comma-shaped bacteria that can cause watery diarrhea. And cholera toxin works with GS. So you look at all your answer choices, and the only one that has GS is adenylocyclase. GS actually is one that increases the activity of adenylocyclase, which leads to more cyclic AMP, more sodium and chloride changes, and then that leads to diarrhea, watery diarrhea. Cyclic GMP and all the other things that are here, right, phosphodiesterase and whatnot, are completely irrelevant to GS. And you have to remember these things. Sketchy micro is one way to remember it, right? Vibrio cholerae, and there's some gas canisters in that image and whatnot. But the other really important thing is just remembering adenylocyclase as well, right, and for water stuff. Cyclic GMP and cyclic AMP are both big deals for watery diarrhea. It's also relevant for E. coli. E. coli also has things to do with stuff like this. So this is just something you get good at the more you study. I'm just going to do it up to number 40 because I'm like really tired. 38, 74-year-old woman with mild dementia is admitted to the hospital because of congestive heart failure and angina pectoris that has progressed despite maximal medical therapy. She has had 3 myocardial infarctions during the past 3 years. Physician recommends coronary angiography and angioplasty. Okay. Patient states that she wants to go home and does not want any medical procedures. That is okay too. She can say that. On questioning, the patient does not know the date, the name of the hospital, or the name of her nurse who had just introduced himself. It would be most appropriate for the physician to question this patient's capacity to make a decision regarding her medical care if the mental status exam showed which of the following, right? Now, this is testing you directly on what I just showed you a while ago, the mini mental state exam. He asked some questions from the mini mental state exam already about the date, the name of the hospital, the name of the nurse that just introduced himself. What else will we ask? So now, I'm trying to figure out not just her mini mental status exam, but I'm trying to see if she is of capacity. Does she have the mental capacity to make decisions for her own health care? And the most important thing would be answer choice D. If she is unable to understand the severity and prognosis of her medical condition, that she is not capable of making medical decisions. Even if she is disoriented to time and place, unable to do serial sevens, unable to do the recall of 3 objects after 5 minutes, or presence of depressed mood. Even if this patient has all those other things in answer choices A, B, C, and E, if this patient does understand the severity and prognosis of her medical condition, she can make a decision about her medical capacity, right, or medical health, right? So just because you have some level of Alzheimer's or something like that does not mean that you do not understand. Alzheimer's means you don't remember, right? Mini mental status exam would check whether or not you're able to remember things and then figure out if you have Alzheimer's or some other form of memory loss. But memory loss doesn't necessarily mean that you don't understand. So you still will answer that 2 plus 2 is 4. It's not a memory thing. It's knowing how to add 2 and 2. So this patient, even though she might have memory loss and she might not be able to do those other answer choices, if she's unable to do answer choice D, that's the one I'm caring about for this question, because we're checking patient's capacity to make a decision regarding her medical care. That's it. That's all you have to worry about. It doesn't matter what the other stuff was about, right? Our question was just about this portion right here. I can't highlight it, right? Okay. Right, so once we figured out this portion, it's funny. In some places I can actually underline shit. In some places I cannot. Okay. But yeah, patient's capacity to make a decision regarding her medical care. The only way I can know she can make her medical care is if she knows how bad her disease is and what can happen because of her disease. Alright, so not last one. One more after this. But this one is a pretty easy one. 3-year-old boy who recently immigrated to the USA is brought to the physician by his parents because of skeletal deformities and failure to thrive. He's had listlessness, irritability, and muscle weakness most of his life. Physical exam shows frontal bossing and flattening of the back of the skull, defects in the enamel of the teeth. Chest wall has a groove that extends from the xiphoid process transversely toward the axillae, with flaring of the rib cage below the groove. Sternal ends of the rib cage bulge at their costochondral junctions, right? These are some excessive descriptions of what's wrong with this guy. The legs are bowed. That one they shouldn't have given because that kind of gave away the answer, right? Bowing of the legs like that is usually due to vitamin D deficiency. Serum calcium and phosphorus concentrations are below the reference range. If the bone was examined, which of the following findings would be most likely? So we know that this kid has vitamin D deficiency because he recently immigrated. So, in America, he would probably not have it. And they also gave you the serum calcium and phosphorus is below the reference range, which is also relevant for vitamin D deficiency, right? So rickets. So we're thinking rickets and the bowing is given. What would we see if we looked at the bone? Absence of cartilage in the epiphyseal plates. No. That makes no sense. Absence of osteoblasts. Why would we have an absence of osteoblasts? There's no reason for that, right? Completely irrelevant. Enlarged osteoclast with increased numbers of nuclei. Also not true. Why would we have that either? There's no problem in rickets with osteoblasts or osteoclasts. That's not the problem there. You just don't have vitamin D. Okay, so then things just don't work the right way. Increased proportions of osteoid, or would this kid have osteosarcoma? Now, there's no reason for this kid to have osteosarcoma, so you just pick D and you move on, even though you might not know if that's true. Increased proportions of osteoid, right? But it sounds like there's going to be increased proportions of some kind of bone that's not complete bone, and that does sound pretty relevant. Children with rickets have pathologic bow legs known as genu varum, bead-like costochondral junctions, rachitic rosary, which they described in great detail, and craniotabes, soft skull. Rickets has defective mineralization of osteoid and cartilaginous growth plates. That's it. It's just defective mineralization. It is not a problem with osteoblasts or osteoclasts, so there's no reason to pick B or C. But if you have an absence of cartilage, well, rickets kids don't exactly grow short. If you have an absence of cartilage in epiphyseal plates, they would grow up to be very, very short, right? Kind of like, it's like their epiphyseal plates just close early. That wouldn't make sense, right? There's no reason for this kid to have osteosarcoma either. That wasn't given. Last question for this video. A 50-year-old woman is admitted to the hospital because of a 3-day history of nausea, vomiting, and upper abdominal pain that radiates to her back. She was diagnosed with HIV 3 months ago and has been adherent with her antiretroviral medication regimen. CD4 is 400, plasma HIV viral load is 50 copies per milliliter, which is pretty high. She appears acutely ill and diaphoretic, temperature is 98.2, pulse is 135, which is high, respiration is 30, blood pressure is low. Physical exam shows epigastric tenderness, abdominal distension, and absent bowel sounds. Okay. So epigastric tenderness is a pretty big sign right there. Results of the lab studies show serum amylase activity of 450, which immediately rings a bell for pancreatitis. The most likely cause of these findings is an adverse effect of which of the following drugs. And they list out a bunch of shit. The only way you would remember this is if you remember this mnemonic. Didanosine causes pancreatitis. That's it. If you don't remember that mnemonic and you just don't have experience with this question either, so you don't know this fact, you're not going to get this question right. Right? These guys have effects. There are some side effects that these antiretroviral therapy medications can have that are unique, and one of them is the didanosine causing pancreatitis. The others, let's take a look at it again. Page 219. HIV therapy. The other thing, there's the abacavir having the contraindication with people with this kind of mutation. This can be given to you in a question. You have to get it right. And then there's these other guys. There's the where is it? I've never really seen a question on this. You could get it. Indinavir is known for thrombocytopenia, nephropathy, and hematuria, but mostly thrombocytopenia, which can pop up in a question. There's one more that I'm not. Oh, infravirins with the sleep, right? Vivid dreams, right? You have to remember this thing, the triple Z for sleep. So infravirins can cause vivid dreams and CNS symptoms. Right, so very, very important. Alright, so that's basically it for this session. I'm just mentally tired, physically perfectly fine, so I'm going to go to the gym now and then call it an early night. And then in the next video, we'll continue from 41 and do as many more questions as I can. Alright, thank you very much for joining. Keep studying hard, guys, and I'll see you guys next time.